Hello to all of our quality-minded listeners, and a special shout out to our Mayo Clinic Care Network members. Welcome to Key into Quality, a Mayo Clinic podcast focusing on healthcare quality, experience, and affordability trends and solutions. Today, we're going to dive into a topic at the heart of healthcare improvement, systematic mortality reviews. Joining me are two exceptional leaders who oversee our health system's mortality review process, which is a vital initiative to uncover hidden patterns, prevent harm, and enhance patient outcomes. Thanks a lot for joining us. I'm Dr. Tim Morgenthaler, a professor of medicine here at Mayo Clinic and vice chair of Mayo Clinic Quality. Co-hosting with me today is my colleague, Sherry Nemec. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation Relationship Manager for Quality at Mayo Clinic. Yeah, I'm really excited to kind of roll up our sleeves and dig into this topic today.
Today's topic, you know how I love history. I can't help
I
myself.
do.
Yeah. But this really, I think, all started with a surgeon up on the East Coast whose name was Dr. Ernest Codman. And he had this bold vision in the early 1900s. He believed that hospitals should track the outcomes of their patients. Kind of an ordinary idea today, but back
Wow.
then it was revolutionary. It actually got him into a lot of trouble. He called it the end result idea. And his whole idea was, hey, it doesn't matter who you are or how important you think you are or what you think you did. Let's look at the actual outcomes of patients. And so after ruffling a lot of feathers and taking a lot of slings and arrows of defense, he started reviewing surgical cases to identify errors and improve care, laying out the ground for what we now probably regard as fairly routine examination of outcomes. And so at Mayo Clinic and other places, that's called our mortality review process. These have really been very transformative. Some of the pioneering work by experts like our colleagues, Dr. Jim Nasons and Dr. Jeannie Huddleston at Mayo Clinic, started this process here, but it's been done at other institutions, University of Pennsylvania and other health systems. This kind of work really has helped our organization find systematic problems in the way we take care of patients. Now, having said that, I just have to drop a little bomb. Listen to the microphone drop.
Uh-oh.
So just last week, groundbreaking study in the British Medical Journal is sending shockwaves through the field, I do believe, because despite decades of patient safety efforts, it revealed strikingly high rates of adverse events in surgical settings, nearly a third of patients affected, and a quarter of the events were deemed to be preventable. So these findings, which are not only exclusively in surgical patients, really challenge us all to ask, how are we doing? How can we do better? What could we do much better than we've been doing? So with the public and regulatory scrutiny kind of dialing up, I think our conversation couldn't be more urgent or more applicable. Let's explore how our mortality reviews can guide us into delivering safer and more effective care.
Sounds good.
And so joining us today is Dr. Brian Beam, who's an assistant professor of anesthesiology and the chair of the Mayo Clinic Rochester Mortality Review Committee, and John McMahon, who's a quality operations manager and is also a member of the Mortality Review Subcommittee. So welcome you two guys.
Yes, welcome.
Thank you.
Yeah, great to be here. Appreciate the opportunity to discuss this topic.
So let's dig in. Maybe you both first could just take a moment and tell us a little bit about yourselves. I mean, how did you get to Mayo Clinic? And how is it that you ended up serving on the Mortality Review Committee?
I'm a anesthesiologist and critical care consultant here at Mayo. Probably my story is pretty common to a lot of other consultants who landed in Rochester, and that I matched here during residency with my wife, who does infectious disease. And I guess the rest is history. I've been on staff for 9 years. Anesthesia is its core, all about safety, and critical care is a great combination with that as well, because we see the holistic patient experience. And so started from very early being involved in M&M type committees, and as went from there. I've been in this role for about 8 months now, and as the chair of the Mortality Review Subcommittee in Rochester, where we review all of the mortalities within the practice. And I think we're just getting going. We've made a lot of changes over the last 8 months with the review process, and there's a great amount of opportunity, like you alluded to, within mortality review and patient safety as we move forward.
Well, how about you, John? Tell us a little bit of your story.
Yeah, thank you. So basically, as long as I can remember, I've really been intertwined with healthcare. I mean, even going back to my days in high school, I've, kind of done everything from cleaning surgical ORs at our local surgical hospital here to being a CNA. I went to a few years of EMT school and really found my sweet spot in quality here at Mayo. I've been in quality for 10 plus years, and really one of the first assignments that I drew was orientating to our mortality review to take over from my replacement. And I had always been driven by quality data and really that high level analytical view of taking the numbers, crunching them, finding the trends. But I really found a passion for diving deep into these cases and watching these nurses and these providers really pick apart the case to draw kind of any straw that they could out of there for potential process improvement. And that really hooked me right there. I said, this is where I need to be. And this is something I can really sink my teeth into and feel that I can make a difference.
You're drinking the quality improvement in healthcare Kool-Aid is what's happening.
Yeah, guilty as
Yeah.
charged.
Once you start, let me just warn you, you may not finish. You get
Well,
stuck
he's
in.
already been 10 years, so I think it's done.
Yeah.
Again, so glad to have both of you here for this conversation. So, if we want to just kind of start digging into those layers a little bit, why don't you start by telling us a little bit more about the structure of mortality review at Mayo Clinic? How do we do it here?
So first, we're a very large enterprise. And so, looking at each individual practice is how we've broken it down. For instance, I'm the chair of the Rochester Practice Mortality Review. Our responsibility is to review mortalities within the Rochester hospital practice, but we have sister processes within Jacksonville, Arizona, and within the health system as well. So it really starts at each individual practice. I think there's nuances with each area because, again, Rochester's a very complicated practice, for instance, with a lot of different moving parts, which the last 8 months I've gotten to work through.
You're really now understanding that, aren't you, Dr. Beam?
It's a lot to bite off. And each practice has its own nuances, but at its core is that we, just as was alluded to earlier, we really dive deep into these cases of mortalities and we look for opportunities. And what's really exciting with this new program, this KaiNexus that we've started to utilize, is that now we're also actively working to close the loop with the practice and make sure that we're enacting meaningful improvements within each practice as we find opportunities along the way.
I know you have a number of people who join in to the process to do the mortality review. Can you share a little bit more about sort of the many hands that support this work?
I'll let John comment a little bit in terms of the Rochester practice. Again, we're very large, and so I can tell you we have about 160 people invited to our committee meeting, which happens every month. We have specific reviewers from each practice, both nursing and physician and advanced practitioner roles. And so we really rely upon those that know their practices, that understand what happens on a daily basis in their practices to look at these cases and feed them back to our group for opportunities.
Yeah, and at the health system level, it's a little bit smaller. These mortality review sessions are run usually weekly. We call them mortality huddles, where all the cases or all the mortalities that had occurred in the past week are reviewed by both a provider and a nurse. We have multiple providers and nurses on that team so that we're not overburdening, any of them with multiple reviews in a week, so that they can take that dedicated time to focus on that case the best that they can. Really, the magic though kind of happens when something's discovered, an opportunity's discovered out of one of those cases, and really utilizing the network of passionate individuals that we have and almost sleuthing out, what can be done better here. And that's really where the majority of the work and really kind of the fruits of the labor pay off.
I'm going to just take a pause here and I'm going to reflect a little bit because you guys probably don't know this, but I was actually part of the very first mortality review committee at Mayo Clinic, which started in Rochester, Minnesota. And I'm not going to tell you how many years ago that was, but it just does my heart good when you tell me how many people are now involved in this process, because when we started, we fit into one small conference room, and it was a few nurses and a few physicians and a couple health quality geeks and scientists. I just want to give a little background to it. At Mayo Clinic, we do a mortality review, and one of the reasons that we started doing a review of cases of patients who had died in our facility, of course, we were interested in why they died, but it wasn't so much to learn why they died. very often that's quite apparent why they died, and it has nothing to do with errors, but rather we had done a controlled trial. It was created by the Institute for Healthcare Improvement. It was called the trigger process, where we just randomly picked cases and we would go through and look for opportunities to improve care. Was there a medication that was not right? Did they miss an infection? Things like that. And then we compared that with a similar group of patients who had actually died in the hospital and looked for those same kinds of opportunities to improve. And what we found is that in patients who had died in the hospital, we often found more actionable and more opportunities to improve. So we felt like if we were going to spend the time reviewing cases, we should review those that could teach us the most. And so we chose that group of patients to look at. So I'm kind of curious now. I mean, I've been out of the process for a long time. Tell us a little bit about what are you actually looking for when you review these cases?
I think you alluded to multiple different things already. How I approach these cases, so we assign our cases to individuals who, again, know the practices and are invested. Really, an overview of the big picture is how I usually start. This patient was already palliative care coming into the hospital and subsequently died shortly thereafter. That unlikely there's going to be opportunities, right? But these unexpected deaths, or one thing that this new system also helps us flag, are these rapid response team initiations, which is something we do in our organization, or code blues, where they had a cardiac arrest. Certainly those will be areas to focus on to see, was there any decompensation up to that point that might have been an opportunity. Oftentimes someone has already reached out to me about a case, and I'll have a few details that aren't in the record that are also helpful. I can tell you from a indicator perspective. So as we go through a case, we'll flag these cases with specific indicators that are related to the mortality. But common things that we see in our practice here, unfortunately, are delayed recognition of a patient condition and failure to recognize the patient as decompensating. So those are things you'd be really digging into the record to see, was that an opportunity that we could have explored. But John went over with our group the detailed list of opportunities and the opportunities by practice here recently. So he probably could speak a little more eloquently about what we're finding and maybe how he approaches the reviews.
Yeah, thanks, Dr. Beam. When we're transitioning over to a new system, one of the things is looking at what went right and what went wrong with your old system. And being, as you say, Dr. Morgenthaler, one of those quality nerds that was sitting there, I'm looking at our post-system closed data, and we're noticing, we have these indicators set up so that we're able to kind of trend opportunities for improvement that our providers and nurses are finding when they're reviewing these cases. So take, for example, we may have a communication issue. Maybe it's communication and then a sub-indicator of inefficient handoff or ineffective handoff, so to say. But within that group, we had a designated category where, okay, it doesn't really fit into an effective handoff. It doesn't really fit into a transfer communication issue or any of our other defined ones. So we have this category of other. And so we kind of got into this habit that we noticed that if it didn't really fit specifically to the letter of the law within these defined indicators, that we'd put it in other. So in all of these different silos of opportunities and sub silos, within them we had few here and there, a handful of pretty specific opportunities, but then we had this large silo of other. So we had 80 opportunities for communication other. We had 50 opportunities for diagnosis other. So when we were going through and doing this new system, it became a necessity to re-engage with our reviewers and bring them in as, key stakeholders and go, okay, how do we get rid of other? What are we missing from our dictionary? And I think that's one thing that's really helped us out. And as we go forward, it's something that we've really mandated, that this can't be a closed book. Looking at, we have COVID, we have other possible pandemics that happen in the future. We need to be able to keep these chapters open so that we can further track these things as they come up and evolve.
What I understand you're saying is, as you go through any given case, there might be many different opportunities for improvement, and you're looking for the frequency of those opportunities so that you can inform the practice and say, hey, in the next quarter, with whatever resources you have, maybe you should focus on this thing because we're seeing that that's a big opportunity to improve. But it's very hard to say, would you please improve other?
Exactly. Yeah, exactly.
Yeah. So you'd like to be a little bit more specific. Yeah, very good. Very good. How has this new system changed your process, and what are some of the challenges and successes that you're finding?
Well, I think first of all, just from a administration standpoint, it's really streamlined it for our quality staff and our patient safety staff that facilitate these reviews. Again, I'll go back to my days 10, 12 years ago when I walked into those rooms, and I mean, I had a legal pad with notes on it of things that I had taken, and all I did was project it up onto the screen, and there was a group of people in a conference room, if you remember doing that. I know it seems like centuries ago, but yes, we did used to do that. And I would take notes on a pad of paper and sit and type them out and look through our quarterly directory to find who's the chair of such and such that I need to reach out to for this question. And really what our new system has done is take that and automate it. You know, it's bringing in automatically the case summaries for Dr. Beam and his fellow reviewers to have right in front of them without a quality or patient safety rep copying, pasting those out of our chart. It's giving them that first sniffle, if you will, checklist of, was this patient rapidly deteriorating? Like Dr. Beam said, going over specific questions of code response and things like that. And the other thing that it does on the back end then is allows us to capture kind of those discrete fields and start trending them for quality data tracking purposes and quality improvement purposes. The other thing that I'll say that has evolved with this system is our ability to eliminate, you know, kind of what I was talking about of a question comes up in the conference room. Hey, we should really reach out to orthopedics to see if this is standard practice. And then I'd go back to my office and email the chair of orthopedics, and I'd get an email back saying, I'm no longer the chair of orthopedics. You got to contact this person. But it allows us now to keep that updated directory right in the system and be able to type in the system and send that kind of subject matter expert question directly from the system and populate it right to the correct person in a timely manner.
Well, that's terrific. So gaining a lot of efficiencies out of that. And we all know how hard it is to get time from very busy clinicians to be able to do these reviews. So I imagine that's given you a lot of gains in that space. So let's talk a little bit about what you think impact of this is for patients, and maybe are there other projects this is being connected to?
Yeah, and the impact I think is potential for major impacts depending on the situations we recognize and the variety of opportunities that we find. I always think of mortality as kind of the canary in the coal mine as well, right? Though we have a mortality that we're studying and we're looking for opportunities, but very often hidden behind that mortality was multiple near misses or other potential patient safety issues that maybe weren't brought to our attention and maybe aren't within the purview of this committee. But my role here in Rochester is honestly to try to put the pieces together, right? We have such a big practice with diverse roles in terms of quality chairs and practice chairs. And so as we find these opportunities, really bringing everyone together to make the practice better. I also look at my role as to step back a little bit and look at the trends, like we said, these overall indicators and the number of indicators in one particular practice, for instance. That's an area we should focus on. The scale of the practice here in Rochester is a challenge. That kind of alluding to the last question, we have about 100 mortalities in the practice a month. And so figuring out how to efficiently review those and have these meaningful conversations is a big challenge, but definitely worth the potential positive upside as we work with the practice to make things better every day.
John, anything you want to add there, or any other projects that you want to mention that this connects to?
No, I think Dr. Beam summed it up perfectly. And that's really the purpose of this, is to utilize and leverage these reviews in these larger improvement projects. And I think that this system really helps do that and really extends our network of connections and ability to pull these very meaningful reviews and their findings into these larger improvement projects.
Can either of you think of any example we might share with our listeners of a trend that was identified sometime in the recent years that has kind of transformed into then an improvement project, some area of the practice where we recognized a trend and said, oh, hey, we need to lean in on this?
One of the examples that we found locally in our region, and this was when I was still facilitating our mortality review huddles here locally, we kept getting these indicator attaches for code opportunities. And this was one of those times where it kept saying code other. We had those defined categories, but we had this large contingency of there's a code improvement there, but it doesn't really fall into anything. So we need to dig into these cases and see if we can find a common cause. Well, the thing was that there really wasn't. It was truly a case where we did have a lot of opportunity within the way our codes were being run. So really what that spurs then is kind of the classic root cause analysis. So we brought together all of our code teams. We happened to be lucky enough to have a code improvement work group already on site. So we got to work directly with them, but really showed them the examples of the reviews of what we were finding, and finding, that there was communication breakdown in some instances. We had technical problems with paging. We also had, for lack of a better term, a lack of chain of command. So we didn't really have that quarterback, of the code team. And so what that did was that really developed a whole new redesign of how our code teams and rapid response teams work locally and how they communicate with each other, and gave them that algorithm to be, if there's a decision here, there's another decision here. This happens, then we move to this. And so everyone was then kind of on the same page instead of just guessing or looking to the person next to them going, what do we do? It really became hardwired in.
That's a great example. And I think that's the kind of thing that you can easily fall through the cracks if you don't have a group gathering and seeing, okay, there's a trend here, because there's no external quality measure that's measuring code efficiency. And yet certainly very important if you're a patient in the hospital and you're very seriously ill. This is a great activity. I mean, I'm amazed. I'm just kind of commenting. You said you have over 100 people involved in this. I have a feeling that most of those people are doing this on volunteer time. They're not being paid a special chunk of their job to do this. And so they're doing it because they care and because they learn and because they share, and it's like you guys, they've kind of gotten bit by the bug.
It's the right thing to do. Absolutely.
What do you guys think are the next steps? Where do you go from here in terms of the development of this program?
And Rochester, and I think enterprise-wide, again, we only started to understand all the functionality behind this new program. To be honest, the vendor's been extremely willing to work with us to continue to modify the process and just to make this as efficient as possible, but as also as effective as possible. So where I'm really excited about optimizing as we move forward and really exploring is the feedback loop that we need to develop with our practices, and we need to mature. And as I alluded to previously, getting to know the variety of different practice chairs and really form those relationships. So then once we do have events, we can very rapidly work together to make things better. That's what I'm most excited about. I think there's also an appetite within the Mortality Review Committee and leadership to be a little more involved in actual project management. Historically, here in Rochester, we've kind of found an opportunity, given it to the practice, but then relied on other mechanisms in order to actually explore that topic further and make the meaningful changes that are necessary. So I think where we have systematic issues, that's where we potentially can shine, because it's not just our one practice that needs to focus on a one individual issue, but rather bigger systematic issues that we need to address. And so that's what I'm excited about. But I think there's a lot of opportunity in the future. And honestly, I think of safety as kind of the flywheel for other continuous improvement efforts. And so using what we find in mortality and safety to help push other improvement efforts as we move forward. That's what gets me excited.
Yeah, I'd agree with Dr. Beam, and it's probably a good thing we live 2.5 hours away, because he thinks very much like a quality improvement individual, and I'd probably be bugging him, knocking on his door, and he'd probably be doing the same to me at 11 at night, with some idea that we want to do or some project that we want to run with. So logistics probably play into our advantage there. One thing that I'll add that I think we'd both like to see too is how do we start to integrate other quality metrics and quality data points in with our mortality reviews. We have a large kind of data lake of quality data that is CMS calculations. We have Vizient, we have patient safety indicators, we have the 30-day mortality rates and things like that. And how do we integrate that and start to leverage that, maybe leverage AI to make us a little bit more proactive instead of reactive on these things? I look especially at like the expected mortality ratios, how do we get more focus on those ones that maybe the data is telling us are unexpected mortalities, and are we finding opportunities there?
Well, wow, guys, you start raising these things and it just starts getting me more and more interested. And I'm hoping that our listeners are just as interested and just as inspired really by the work you guys do. I just want to express gratitude for you for devoting your time to talk with us today and to share your enthusiasm and your vision for the work that you're doing. And kudos to you and all your colleagues. Thank you for the work that you do to make care better for our patients and make it better to deliver for all of us, because we know that there's a beautiful synergy and joy there about doing a job and doing it well and serving patients. So thank you so much for joining us.
Yep, completely agree. Thank you so much.
But we do have to come to the end of our podcast, and we're very glad to our listeners that you've joined us. We hope the information has been stimulating and valuable to you. Again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges for your organization. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you're listening. You can also follow us on your favorite podcast platform. Also, let others in your organization know about the podcast so that the information can be spread. Until next time, goodbye.